Hello, thank you for the very kind invitation to present at your meeting. I'd like to spend the next short while just talking about the airway, past, present, and future. My name is Anil Patel. I'm an anaesthetist in London, and I have been practicing as an anaesthetist for 32 years. I need to let you know before I start that I've helped to develop a video laryngoscope. I have received funding from F&P Healthcare for research, consulting, and travel and accommodation. And I am a trustee of two airway-related charities, Facing the World and Exovent. I work here in London at the Royal National ENT Hospital and University College Hospital, which is, as you can see, in central London. It's a very nice place to be. And I was actually an undergraduate here. I was born in London. I have lived all my life in London. I went to medical school in London, and I now work in London. So I have not really travelled very far. Today, I would like to talk about these different topics around airway practice. So let's talk about the supraglottic airways, the laryngeal mask airway. We'll talk about cricoid pressure. We'll talk about front of neck airway practice and human factors and airway management, video laryngoscopy, the role of nasal high flow, Thrive, and then some future technologies that may be useful. So the first thing to say is the laryngeal mask airway. Many of you will be familiar, but Dr. Archibald Brain, what is the inventor of the original supraglottic airway called the laryngeal mask airway. His first publication was in 1983, in which he described a small series and the use of this completely novel concept in airway management. If you are a trainee, or if you are a consultant that has essentially been involved in anaesthesia for the last 25 years, you will know nothing else other than supraglottic airways and endotracheal tubes. You have to remember that these sorts of publications, or this publications, the only options we had for airway management were a face mask or an endotracheal tube. So this has totally and completely revolutionized airway management. And Dr. Brain was the inventor of this technology. And of course, since this technology has been incorporated into every airway practice throughout the world, there have been many, many different variants of the device. And they vary depending on how deep the cuff of the supraglottic airway sits. They vary in terms of the material of the supraglottic airway, whether you can pass an endotracheal tube through, whether you can separate out the elementary tract and the airway tract, as it were, and the incorporation of the so-called second generation devices. But what's important is to recognize that all of these devices, wherever you are, the common original theme for all of them was the 1983 paper from Dr. Brain. And indeed, that paper has been quoted more than any other paper in the British Journal of Anaesthesia in airway practice. It is the most highly cited paper, well in excess of 1,500 citations, which is a phenomenal number. Another interesting aspect around airway management and the use of supraglottic airways is this report audit of national practice in the United Kingdom in 2011. The authors were Tim Cook, Nick Woodall, and Dr. Chris Firk. And this is a major undertaking looking at all of the airway deaths, brain damage, and emergency surgical airways in a country for a 1-year period. And we don't have time to go through all of this. And if you go to any airway talk anywhere in the world, this paper and this publication always comes up. It is the benchmark of of national practice in the UK. And what was a common theme in over 10 years ago was that to use a supraglossic airway, we needed the correct patient selection. We needed to limit the use to appropriate surgery. We need to understand the limits of that chosen airway. We need to be experienced in both the insertion and the fixation. We need to understand second generation devices, problems during maintenance, and problems at emergence recovery or removal. Interestingly, in the 1983 paper, and I recommend you read this paper, it's not a very big paper, Dr. Brain, 42 years ago, or 32 years ago rather, discussed all of these elements in the original paper. 10 years ago, in NAP4, we're still talking about them. And right now, we're 10 years later, more than 10 years later, we're still talking about these things. These are all very important things. There is a tendency to regard supraglossic airways as a very low experience, low insertion, low knowledge-based device. And in some ways it is, because a good supraglossic airway you can pick up and use, and you'll have a reasonable airway. But to really understand it, you need to understand all of these issues. And I would go as far as to say it is a fundamental skill. It cannot be that if more than 50% of international airway practice utilizes a supraglossic airway, and we as anaesthetists are experts in airway management, then surely if we are using something more than 50% of the time to manage an airway, it has to be a fundamental skill. And whilst we pay attention to patient selection, indications, contraindications, insertion, etc., when we undertake laryngoscopy and intubate a patient, I think we sometimes don't provide the same degree and detail of attention to supraglossic airways. And I think we should do, because to really maximize the utilization of these devices and really understand these devices, we have to understand what we're dealing with, and we have to understand them. These are not devices, as airway experts as we are, that you should just pick up, never having read them, never having understood them, just put them in and expect everything to be okay. We need to recognize that this is a skill set that we need to require, that we need to acknowledge. The second area of interest, I think, is the use of cricoid pressure. Now, over 30 years ago, when I was starting anaesthesia, any suggestion of a full stomach, everybody got cricoid pressure, and we placed our what we thought was the correct pressure, and we were all told that the effect was that the cricoid ring would compress the esophagus, which was behind the cricoid ring, and that it would prevent material within the stomach coming back up again. And actually, as the years have gone by, we've recognized that maybe the anatomy is not quite what we thought it was. It may be that actually in many patients, the esophagus is off to the side. And it may be that actually it's the whole laryngopharyngeal apparatus that is compressing the upper parts of the hypopharynx and the esophagus. To some extent, it doesn't matter. What we need to recognize is that we are attempting to prevent material coming back up from the stomach up into the oropharynx and then obviously into the trachea, and prevent aspiration. So our understanding of the mechanism of what's going on with cricoid pressure has changed. What hasn't changed is that there is discussions at the moment, and people are in different camps. Some people will apply cricoid pressure, and there is a very significant move for people not to use cricoid pressure. And the reason they are suggesting that we should not use cricoid pressure is because the application of that cricoid pressure can sometimes affect the airway, can sometimes affect laryngoscopy, and it can be detrimental. And that may well be true. I think, and many people think, that actually it's still sensible to use cricoid pressure, but we should be ready to release it. If we are running into problems, if we cannot visualize, if we have a problem with the airway, then actually it's okay to release the cricoid pressure. And that's the change from 30 years ago. 30 years ago, we never released the cricoid pressure. Now I think it's okay and it's recognized that we should be releasing the cricoid pressure if we run into problems. So when might we release the cricoid pressure? We might release it if visualization of the airway is extremely difficult. If we find that we cannot intubate that patient and we need to place a supraglottic airway, then as you can see, the supraglottic airway tip, depending on the type of supraglottic airway, sits around the level of C7, around where the cricoid cartilage is. And therefore, to have a correct placement of that device, you need to release the cricoid pressures to place the supraglottic airway. This is obviously in a rapid sequence intubation where we've not been able to intubate the patient. So I think it is maybe we may not have maybe we should be still using cricoid pressure, but release it if we have any issues with it. And that seems to many of us a sensible, pragmatic approach. The idea that we just never use it because it might create a problem, and then occasionally we have aspiration, is also, many of us feel, not a sensible way to go. What about the front of neck? The great debate around whether we should be using a scalpel surgical airway type technique or a needle type technique. In terms of the approaches and the literature base, there really is no great evidence for one particular technique. But there are enough reasons to choose just one technique, and that is that if you have everybody doing the same thing, then there is a standardization of that technique, and therefore the likelihood of improvements in success rates with that one particular technique. There is evidence emerging, particularly from the Airway app, which is an app that allows people to introduce their experience of what's happened with these sorts of emergency front of neck airway experiences internationally. And what you can see is that the surgical cricothyromy, the bougie-assisted cricothyromy, the scalpel bougie technique has the highest success rates internationally. And that's been replicated in some more recent follow-up on this data. So there is an evidence base emerging that appears to show a superiority of a scalpel bougie technique over other percutaneous type techniques. And another very interesting aspect in terms of front of neck airway is this idea that if you have lots of different ways of being able to do something, and also lots of many different specialities coming to the surgical airway, to the emergency surgical airway, it seems illogical that everybody has a slightly different way of doing it. The surgeon comes along and wants to do one particular technique. The anaesthetist comes along and wants to do one particular technique. There should perhaps be a standardization of the approach. And again, that feeds into that narrative around a single approach that everybody, whoever they are, understands, has practiced, and will probably have a higher success rate. Something that that we're beginning to appreciate over the last decade or so is the importance of human factors and airway management. When I started anaesthesia, for most of my career, apart from the last 10 years or so, most of our literature and my experience and our discussions and our lectures have been based around bits of equipment and how good it is or how bad it is or how successful it is. We haven't really discussed or understood really human factors and the whole interplay between different people, the organization, where we are, how we are, what we're doing. And there are some very important lessons to be learned from an understanding of human factors in anaesthesia. And here are two recent publications from Fiona Kelly and her group around human factors in anaesthesia, and particularly around airway management as well. Video laryngoscopy is all around the world. We've known about it for many years now. And I'm not going to talk about the details of different types of video laryngoscopy, the pros and cons of different video laryngoscopies. All I'm going to really say is that I think now in 2024, it's pretty clear from the evidence base and from all of our experiences that video laryngoscopy is a superior technique for visualization and for placement of an endotracheal tube for most people, most of the time, because you have an improved view. And this is a very simple way of trying to show that. A standard Macintosh laryngoscope, we cannot see what the tip of the Macintosh blade is visualizing. We can only see in a straight line with our eyes. With a camera, depending on the angle of the blade, we can look more acutely around the corner, and therefore our visualization has been improved. And with the acute, the third image, which is a hyperangulated blade, we now have another secondary issue, which is to try and place the tube around that hyperangulated blade, a more acute angle. And again, with experience and an understanding of what is required with either stylets or bougies, that is perfectly feasible. And again, the literature base is showing that that is significantly superior to trying to place tubes with direct laryngoscopy and a straight line. So I think there is no doubt that video laryngoscopy is a superior visualization and has higher success rates for tracheal intubation. And of course, that's why it's adopted and has been adopted internationally. I want to now just talk about shared airway management. I work in a specialist ENT hospital. I work with many laryngeal surgeons who all have subspecialist laryngeal interests. And as you can see, I have personally anesthetized over 6,000 airway procedures, of which there are 5,000 plus jet ventilation procedures and a lot of nasal high flow Thrive procedures for shared airways. I've seen a lot of critical airways, and I've seen a lot of stridorous patients. Now, I'm telling you this because I'm going to show you an approach that many of us use and my institution uses. The problem with so much of the critical airway literature base is that there is no literature base. So I would be delighted to explain to you and tell you what the latest randomized double-blind controlled trials around obstructed airways are telling us what we should do. Unfortunately, there are no double-blind randomized controlled trials around an obstructed airway. And so really we're left with groups of people, international or national summaries and experience base. And I'm going to tell you what many people how they approach these critically obstructed airways. The key decision in this process is whether you keep the patient awake or asleep. And when they're awake, we can either do an awake tracheal intubation or we can do an awake tracheostomy. And if they're asleep, most people nowadays will go for an intravenous induction. Personally, I never do an inhalational induction on these patients, but others may opt to do that. But the key decision is still, do you manage these critically obstructed airways, critical airways, awake or asleep? Now, that decision will be guided by the experience of that individual, the institution that they're working in, the equipment, where they are, what they're doing, and the people that they have around them. Is there an experienced head and neck surgeon that can do an immediate front of neck airway in a controlled manner if you opt to go asleep and the airway is lost? So all of those things come into play, but the key decision is for you at that moment in time with the people around you in the institution that you're with. Is it safer to do it awake, or are you comfortable in an asleep technique? The different techniques that are available, and again, these have changed over the last, certainly in the last 3 decades that I've been practicing. Spontaneous ventilation, maintenance of spontaneous ventilation. We might opt to put a small microlaryngoscopy tube down. And of course, that will be determined by the degree of the pathology. So the first line in all these images, you can pretty much do whatever you want. The second line, the airway is getting more challenging. The hole is getting smaller. And what we can do is starting to get limited. We may not be able to place a small tube because the hole is just not big enough. And then the last line with an obstructed airway in extremis with tumor or, for example, epiglottitis, the second image on the last line, your options are getting very limited. And at this stage, the awake asleep decision-making is absolutely critical. You can put a laser tube down if you're lasering. You can insufflate. You can use what are called intermittent apnea techniques, jet ventilation techniques, and nasal high flow thrive techniques. And more recently, with the placement of a very small tube, flow controlled ventilation as well. So that's a brief summation of the different surgical techniques. Something that I think is appropriate and important is to recognize that we all get our decision-making wrong. So sometimes we think we are going to do something asleep and it becomes extremely difficult and we run into problems. And sometimes we do something awake because we think the patient's going to be very difficult. And in fact, they turn out to be straightforward. This is a paper from Dr. Rosenblatt from Yale in the US. And this idea of placing a small endoscope while the patient is awake and actually just looking at the pathology and looking at what you're dealing with changes the awake or asleep decision-making cycle. And this is very important. It either reinforces that this is an extremely difficult thing, or it may give you some confidence that you can put the patient, induce anesthesia. And indeed, when they looked at this, they found that it did change their decision-making. So that's an important and useful thing to do. These are the most recent Difficult Airway Society guidelines for awake tracheal intubation. They were developed to try and make it a little bit more helpful for individuals that very rarely do awake tracheal intubations. Many of us who use these techniques all have our particular ways of doing it, but this is just a standardized technique for most people who are actually not doing these things very often. And indeed, if you look at the international literature base, in the big hospitals, the large hospitals around the world that have airway experts that are perceived to be doing using awake tracheal intubation techniques frequently, actually, if you look at the numbers, they are anywhere from 0.1 to 1% of all the intubations that take place. So it's a very small number of procedures. So we're never going to be in a position where everybody is experienced with this. So this is an attempt to try and help people who do this occasionally, and it may prove to be useful. It's open access from the journal. I'd like to now go on to something that I've been involved with over the last decade or so, which is the evolution of nasal high flow from its very first description in the 1960s through to about 2 decades use in the critical care environment, and more recently into the anesthesia world in the last 10 years or so. And the reason it's important is an understanding that we all know that the sicker a person is, the smaller they are, the bigger they desaturate once they stop breathing. And if we can have some means in which we can extend that apnea time, make that intubation process a little bit less stressful, that's a very useful thing to do. And it introduces this concept of peroxygenation. Of course, this is nothing new. We've known about this for 100 years. It's just that we have not been doing it. When I started anesthesia, 32 years ago. Occasionally, we would pre-oxygenate. 20 years later, we were pre-oxygenating most patients. But after we'd induced anesthesia and we took the face mask off, we gave no oxygen. And then we did laryngoscopy, and then the patients would desaturate sometimes, and then we would have to go back with a face mask and re-oxygenate. And that process is not ideal. If you can extend the apnea time by supplemental oxygen through the nose during that whole period, that is makes that whole process less stressful and a little bit better. So this process here, where we can supplement and retain and maintain the oxygen saturation for a significantly longer period, is useful. And it becomes really very useful when things are difficult, when we're getting stressed, when we know the patient's going to start to desaturate. It just makes the whole process for us a little bit easier. And that's why I think if you look at every national and international airway guideline, whether it be from the UK, from India, China, Spain, Canada, America, Australia, New Zealand, China, Switzerland, Germany, Brazil, every single national airway guideline in airway management in the last 10 years has either recommended or recognized the usefulness of nasal high flow for airway management. So it's remarkable, really, that 10 years ago, we had no publications on this. And in 10 years, we have gone to national and international recognition of the usefulness of nasal high flow in every international airway management guideline. Virtual endoscopy. This is a paper from quite a while ago now, 2011, over 13 years ago. Even then, it was recognized that with the right image processing, you could have virtual run-throughs and therefore know what you're going to be dealing with. And that's a sensible thing to do. And that process has come along quite significantly. There are now books. Dr. Shalik from Qatar has written a book on this subject. There are publications on this subject, and this is now quite possible, and we can understand what we're dealing with before we even put the patient to sleep. Airway ultrasound, as we know, is very useful. Michael Christensen and Wendy Toe have really been exponents of this technique. And I think if you go to any airway meeting, there is a recognition of how useful this technology is. And many people around the world are using this technology for identifying the cricothyroid membrane. There was discussions around how useful it is as a predictor of difficult direct laryngoscopy. And this is still not sure whether that works, and probably not for most people unless you are very experienced. Obviously, we know about its usefulness for gastric ultrasound, and it seems so obvious that we should be doing this so that we know whether the patient has a full stomach, and therefore we can manage our airway appropriately. And finally, this is work from Switzerland, from Patrick Schutker's group, and they for a long time have been utilizing facial imaging. And this is a slide from quite a few years ago, and this has come on leaps and bounds, actually, particularly with the advent of obviously artificial intelligence and the ability to be able to identify who's going to be difficult and who is not going to be difficult. And of course, this is for the future. Perhaps in the future, we will be able to scan a face, scan inside the mouth, analyze voice patterns, which are very useful, look at breathing pattern analysis, again, very useful, with the use of augmented reality and artificial intelligence, have a high sensitivity and specificity to predict who is difficult and who is not difficult. Currently, we are not very good at sensitivity or specificity for predicting who is a difficult airway and who is not a difficult airway. So this is something that's obviously still very important. So in summary, I've spent the last half an hour or so just discussing the importance of supraglottic airways, how they were introduced in 1983 by Dr. Brain, and how any supraglottic airway that we use is a variant on his original theme. We've talked about cricoid pressure. There is a tendency and a significant group of individuals who believe that we should abandon it. Many of us believe that we should still use it, but be prepared to release it if it's compromising our ventilation or our visualization. Front of neck airway, there seems to be literature coming through that a surgical standard bougie scalpel technique for most people around the world has the highest success rates. We are recognizing the importance of human factors, and this is a subject and a topic that we've neglected for far too long. I think it's pretty clear that video laryngoscopy improves visualization and improves success rates for tracheal intubation. We have gone from a position where most anaesthetists throughout the world did not know what nasal high flow was 10 years ago, to a position 10 years later where every international airway guideline recognizes nasal high flow for airway management. And in the future, hopefully, we will improve the sensitivity and specificity of our ability to predict a difficult airway, and then have visualization tools that we can practice and improve our success rates. So thank you very much for listening. A couple of things, some meetings that hopefully we will see many of you at. The first is the Difficult Airway Society meeting in November, and the second is the World Airway Management meeting in Italy in 2025 in November, and that is the largest airway meeting. We're expecting 2,000 people. The last meeting we held in Amsterdam in 2019. So this is a meeting every 4 years or so. And the last meeting had 1,700 people from 73 countries. So I hope to see you either this year or next year. Thank you very much for listening. Thank you.